should I say the MC gave the profile. I'm Dr. Livingston Asem. I hold a PhD in health policy and management, MSc in health informatics, and BSc in information and communication technology. So I currently am a postdoc fellow in Market Plus project. So by this project, we are currently doing what we call surveillance or exploring the feasibility of using ANC or first ANC attendees as a sentinel population for monitoring malaria transmission in our communities. And currently, this project is in Volta region and it covers 9 districts. And within each district, we select 3 sites. And these sites include urban, peri-urban, and then rural sites. And so we collect data from all these sites to monitor transmission. And currently the results are so interesting. And one of the interesting things we discovered is that previously, all of us know that Ghana, most of the malaria species that we know is the P. falciparum. But currently, we are beginning to see a little bit higher numbers of P. vivas, which is something we need to look out for as far as malaria is concerned. So this will inform future drug procurement, future case management procedures, future tailoring of interventions. And this is just a brief information on my postdoc project that I'm currently doing. So now let's come to what I'm supposed to present on today. So as a way of outline, my presentation will look at the definition, purpose, and importance of EMRs, or electronic medical record systems. We'll also describe the fundamental and a component of an effective EMR. We'll try to explain some of the core principles governing electronic medical records management. We'll also discuss some data quality issues extended to privacy, security, and confidentiality. We'll look at some of the change management during implementation of EMR. We'll also try to identify some of the common challenges that apply. So now somebody will ask, what is electronic medical records? An electronic medical record is a digital version of a patient's medical information maintained within a healthcare facility. It contains the patient's demographics, medical history, clinical notes, diagnosis, medications, laboratory results, images, vital signs, treatment, care plan, clinical outcomes, and sometimes they include allergies that people have. So there are a lot of terminologies that are used within the space of EMR that we must take note of. We have EMR itself, EHR, and then we have the EPR. So the EMR is electronic medical record, EHR is electronic health record, and then EPR is electronic patient record. But now let's see the difference. Electronic medical record primarily focus on the records within a healthcare organization. And it supports the clinical care and facility level management. So when we talk about EHR here, it's broadly longitudinal health records, and it's designed to facilitate information exchange across healthcare organizations. So electronic patient record is the general term for digitally maintained patient information. So anytime you use the word electronic patient record, it means there is a form of digitalization of the medical documentations of a patient or a client. So if you put this in a Venn diagram, you can see that the universal set is a patient health record. And then the subset, which have the other sets, is electronic health record and electronic medical record. So somebody will say, why is it important to even have electronic medical records? This is important because it helps you to improve availability of patient information. It supports continuity of care. It reduces documentational errors. It improves clinical decision making. It also facilitates communication among health professionals, supports M&E activities. It improves health information management and also generates data for research and also planning. So conventionally, we used to have paper-based records, and currently we are moving towards the electronic health records. So the traditional paper records are physically stored, and with no time, these papers occupy large volume of spaces. They are difficult to retrieve. Sometimes over time, if you want to retrieve another patient's record, it becomes a whole lot of hell. There are vulnerables to, it's also vulnerable to loss and damage because sometimes water can pour or wherever it is stored. If there are water leakages, the records get damaged. There's difficulty to share. Sometimes concurrently, one person can only use one record at a time before you can transfer to the next person. So even if it is a register, that is the way you do it. There could be possibility of a duplication because if somebody's record is lying on Mr. A table and hasn't gotten to Mr. B and Mr. B cannot find the record, there is a possibility that he will just go ahead and create another record. So these lead to what we call duplication. And sometimes it becomes difficult and time consuming to manually aggregate some of these things. Especially, we compile monthly returns within the Ghana Health Service setting. A lot of reports is generated mostly at the end of the month, weekly. We have the IDSR report, we have monthly, quarterly, and half yearly. It becomes a lot of hell or a lot of heavy tax to be able to aggregate some of these things. But when it comes to the electronic record, they are rapid, it's easy to retrieve them. Information is also well structured. It gives an ease of sharing, automated reporting, it improves data accessibility, and it has a potential for decision support tools. So you can see that automation gives you a more advanced or a more better information structure than the traditional paper systems that we have. So fundamental to every health information system, EMR or electronic medical record system also have key components. And for every effective electronic medical record, generally have the following key components: hardware, which we all know, software, databases, they have network and connectivity, they have the people layer, they have the set of instructions, what we call the processes. There are also policy, procedures, laws or guidelines. There are also security control systems. There are also governance structures, who should have access to what and what not. There are technical supports. So all these layers generally forms the main component or the fundamental component of every EMR. So now let's come to the people component. These people are central to every electronic medical records. And for it to be successful, you need human beings that are either from those that are trained at the lower level, high level, or middle level. All of them must have some level of training. And the key users of MHR include the physicians, the nurses, the midwives, the pharmacists, laboratory personnel, health information officers, administrators, the IT personnel, and sometimes in some cases the patient also are part of the people component of the EMR. Now the hardware infrastructure. This hardware includes the desktop computers that are used, the tablet, the laptops, servers. We also have the barcode scanners, the printers, network infrastructure or equipment, the backup, the power protection systems. And with all these things in place, forming the hardware, but there are important things that you need to know here, or consideration that you should have in your mind. The EMR hardware infrastructure must be reliable. It must have an appropriate specification, and it should also be in a way that you can regularly maintain it, ensure security, and also plan your replacement plan, because whatever infrastructure you put in today, tomorrow, most of them will run down. Even if it's a computer, there will be breakdowns, and you need to properly plan for some of this during your implementation phase. Now let's come to software, which is also one of the third component. Softwares provide what we call the functionalities that help you to, one, register patients. You are also able to document the clinical encounters. You also order your investigation. You record your diagnosis. You manage your medications, generate reports, manage your appointment, or you schedule your appointment. It also supports billing, and it helps you also to retrieve information whenever the patient comes to the facility. The software play these roles. We also have the database as one of the components. The database helps you to store the patient and system information. It contains patient identifiers. That is their name, their phone number, their ID. These are things we can identify with a patient. Demographics, their age, their sex, clinical encounters, diagnosis, procedures, laboratory results, medication information, provider information, and it also have audit log. So every database that you maintain on the patient or the client must be accurate, must be available, must be secured, and must have all the integrity in it to help you provide
Hello,
service
sir,
to the
Doc.
client.
Hello,
Yes,
sir, Doc. Yeah,
yes.
thank you very much. I'm sorry to interrupt. We have some of our genius as part of us. If all the terms do work to break them down, all the terms. For
Okay,
instance, you
so
mentioned the audit log. For instance, somebody may not know, so break
okay,
everything down to their level. Thank you very much for
okay,
your.
okay. So well noted. Thank you for that reminder. The audit logs are just audit trails that are designed that goes with software. So anytime somebody log into your system, whatever activity it does, it log in the audit trail. So at every point in time when you want to refer to your system, in case there is any vulnerability, or even if there are no vulnerability, it makes you keep track of who comes in or to use or not to use your application or your database platform. So that if there are issues, you know where to trace or track it to. Let's assume somebody is using your facility to diagnose or extort money from people. The audit trail will be able to trace to every user that uses the system, and by so doing, you are able to know who does what and who does and why they do it. You'll be able to know from that. Okay, so we also have network connectivities. Currently, the Wi-Fi, MiFi technology has become more handy, but the local area networks are also there. We have the wide area network. We also have the metropolitan area network, internet connectivity, the wireless network, or let me start with the local area network. These are connectivities that we use peer-to-peer cables to connect one PC to another PC, so, and the two PCs are able to communicate to themselves or communicate together. We also have the wide area networks, which you are in two different locations, but different locations, but you are able to communicate using the wide area network. Internet connectivity, this is commonly what we know in our neighborhood. Everybody with your phone now, you can connect to the internet and be able to send and receive messages. We have the wireless network. We have secure remote access. So this, at every location, there are different access levels that are granted that as a user, if you've been granted access to every electronic MR platform or EMR platform, you'll be given a username and user password. This will help you to be able to log in. So in a limited or a resource constrained country like ours, or setting like hours. Anytime you are planning this, you should always consider the unreliability of the internet so that alternative arrangements, alternative plans could be put in place to supplement your internet connectivity if you are going to use internet in managing your system. If they are limited bandwidth, you know what to do with their power interactions. You need to put in a standby generator or a standby backup plans or a standby power. Let's call a typical example is the UPS that we know. These are power batteries that could power, some can go as long as 5 hours before maybe the normal power will come back. There are a lot of offline functionalities. For example, the DIMMs or the the DIMMs, the other one that we use for the offline, the transactional data management. So this, we can have the offline functionality that enable you to enter data. So whenever the internet connectivity comes, you just have to upload your data set into it. These data, you can synchronize them time in, time out. So you can synchronize your backup. So you are able, once you put in all these structures, you ensure that your data will be safe and connectivity will be smooth. So now let's see a typical EMR workflow. A typical electronic medical record starts with what? Patient registration. So within the registration table, there are a lot of things that go on. You get to know the patient's name, age, sex, the patient's phone number, you assign an ID. So all this is known at the patient registration table. Then you go to the appointment area where they try to track. I mean, you sort the patient into who is going to, maybe one is going to eye, another one going to the dentist, another one going to the uh, to see the dermatologist, another one go to maternity. So you do the charging so that everybody knows where he will go to. Then you go to the clinical consultation itself. Then you move to investigation, diagnosis. Then you move on. Once you diagnose and know what the condition is, then you draw your treatment plan for that patient. And based on that treatment plan, you recommend what kind of medications will be used to address the treatment needs. And this patient goes to the pharmacy, picks his drugs, and then after going home, he has to come back for a follow-up. And then the next level is how you report at the end of the month or at the end of the week, what data you get. So every EMR workflow typically look like this. So if your system is not well structured or it's not designed this way, there's a possibility that there will be a duplication of data entries. There could be delays. User frustrations could set in. Workarounds could also be a problem. Poor data quality could also happen. And so you need to, once it's designed, workflow is clearly designed because the workflow is supposed to mimic how the manual system actually work. Yeah, so once it has to mimic it, it should have all the characteristics of it so that everybody can still see his role and be able to play it effectively. So we've already spoken about these patient identifiers, and earlier on I mentioned everybody who comes to the facility at the registration table, you are given unique identifier. Your demographic information is known, and we identify there should be an identity that helps us to verify whether it is actually you, and we do everything possible to also avoid duplicate or record that to re-register the same patient over and over in the EMR. All these things we try to avoid it. So when it comes to the patient registration, it should capture the patient's name, and every medical records person knows this very well. You should capture the patient's age or date of birth, sex, addresses, contact information, emergency contact, or sometimes in some of the software you see next of kin, unique patient identifier, and sometimes we add their insurance. Or in Ghana, for instance, insurance is one of the key things you need to add. The key principle here is that we need to collect information that is important, relevant, and is also accurate. So let's come to the clinical documentation. Clinical documentation should be accurate. It should always be complete. It should be timely. It should be clear. It should also be relevant and structure where appropriate. It should be attributable to the person responsible, or attributable to responsible provider. So whoever is providing the service, we should be able to attribute these clinical documentations to you. So if there are 10 providers, every documentation that is done here, we should be able to attribute it to each of the 10 providers. So data quality is also something we cannot gloss over. So high quality data is key when it comes to electronic medical records. Accuracy, completeness, consistency, timeliness, and then validity. So for accuracy, we check whether the data is correct, it represents the patient or the patient's event. Completeness, it contains all the required information. It is consistent, it does not contradict other records. So if you say the person is called Kofi, does it, every record has the same Kofi in it, so there's no contradiction. Timeliness, entered and available when needed. Validity, it conforms to defined standards and rules. So when we talk about data accuracy means that information recorded in the EMR reflects reality. Example, correct patient age, correct medication, correct laboratory results, correct diagnosis, and then correct date of services. So the strategy here is that you have to do what we call data validation. Any data you capture, you need to verify it. Make sure every user of the system is also trained. And during the process of automation, you need to also do what we call automated checks. So at every point in time, you need to do what we call data or routine data quality audit. Yes, so malaria control, for instance, that they come routinely, pick an indicator, they try to run it through the system, check from the baseline document to the summaries to see whether it is summing up. So this is the kind of data quality audit you can do. You cannot do data quality audit for every indicator or every data element, but you can select some few key ones and you can review them. So data completeness, incomplete records will compromise your patient's record. So patient records, so incomplete records can, again, incomplete records can compromise patient care. So things like disease surveillance can also be compromised. Research can be compromised. The monitoring programs get compromised if your records are incomplete. Management decisions are compromised. And so to address some of these things, you must have fields that are mandatory, and you make sure that every data entry clerk enters those fields. You must also make sure that your data sets are complete. For instance, we have DIMS. When you enter a field, it tells you the number of fields that are complete. So fields that are not complete, it gives you an indication, red colors, so that you can go back to field. We also have users, you need to properly train them. And the users, once in a while, you must also do what we call routine data quality assessment. So in every organization, you need to make some budget allocation for data quality assessment, because for your data to be accepted, be it an electronic or the paper-based, you need to provide a report of routine data quality. So that is how people can give some kind of level of integrity to your data that you compile. So timeliness, I mean, the data that is timely is as important as whatever, because if you produce a report that is way behind schedule, nobody will use your report, no matter how interesting the findings or the results are. So clinical decision making gets affected if the data is not collected at the right time or timeliness is not adhered to. Disease surveillance become delay, outbreaks pass without anybody detecting it, monitoring of programs delay, data management and decisions becomes a problem. So let's look at one example. The malaria test result enters several days after a patient clinical encounter may be less useful for immediate clinical decisions. So if you enter this way after, nobody is interested. But if it is on time, everybody gets into motion with it. Confidentiality. Okay, so confidentiality is also one of the key data quality dimensions that we need to adhere to. Confidentiality means protecting patient information from unauthorized disclosures. An example of confidential information include the HIV status of patient is supposed to be confidential, mental health information about the patient confidential, laboratory results, diagnosis, medication, and also sexual and reproductive health information. These informations are critical. There's no way within the health system that you should divulge or give this information out without proper authorization of the system. No matter who you are, you have to seek a high level clearance for the system before this information are made known. And in fact, they cannot just be in the raw state and people will see it. They need to be summarized in a way that individual identity informations are lost and you cannot trace it even to anybody. And so in all, it means only people that are authorized or individuals that are authorized to have access to this information are required or legitimately are allowed to have access to such information. So it cannot be everybody. Privacy. Privacy concerns the individual's right to control access and the use of personal information. An effective EMR should incorporate appropriate access controls, privacy policies, consent process where applicable, secure communication, appropriate information sharing policies. So security protects information from unauthorized access. Unauthorized access means that the person is not authorized to use that or to have access or to see that information. Unauthorized modifications, the person is not allowed to make changes. Data losses. Security is a security problem. Data theft, malware, cyber attacks, accidental distractions. These are all security issues when it comes to EMR. So a comprehensive security program must include first the person or the people. Processes must be well documented, and the technology must be also well fashioned so that it will be able to meet the needs. Other than that, your security is without security. So every security system should have these three purposes addressed in your security system. The people, the process, and the technology must be clearly addressed. So in security, we call something the CIA trade. It's a fundamental information security framework. And this framework has three things: confidentiality, integrity, and availability. So when you are designing security systems, you should always have in mind these three friends. Confidentiality, what you mean is that only authorized users can access the information. Integrity here is about information remains accurate. It is not improperly altered, or nobody goes to alter it unnecessarily. Then availability, even with all the security dimensions you put in, the data should also be available, or authorized users can access the information when needed. Because when you put in all your security dimensions and even the authorized users are not having access, it means your security is. So there should always be that balance when it comes to security management. So in security, you must also know what we call user authentication. Authentication verifies the identity of a user. There are common ways of doing this. All of us know the username and password bits. This can also be done in a multi-factor authentication approach. So everybody, you have a username, you have a password, you log in with your password, and then it gives you access. You can also have a multi-factor authentication. That is more than two. So instead of the username password, they can add a token where the system is triggered to send a token to your phone. They use the token to log in. You can also have what we call the smart cards. So the smart cards are just like our banking cards. You slot it into a machine, then it gives you access. We also have the biometrics. You can use your fingerprint to grant you access, or you can use your iris, or you can use your palm scan, whatever, to grant you access. We also have other systems that have single sign-on. So you just put in a code or a numbers, and then it gives you. So for every group practice, users should have individual accounts rather than sharing credentials. I remember those days people used to share DIMS account, the whole district. Everybody's having one account, they are using it to log in. Now, this is not a good practice. Every individual who is having this access to the system will need to have individual account so that you can monitor what everybody is doing. The audit trails can know. So access control is also another security dimension that you need to clearly or critically look at. Users should receive access according to their responsibilities. For instance, you have physicians, you have nurses, you have pharmacists. In a typical hospital, you have laboratory staff, you have the health information officers, you have the administrators, you have the IT staff, and each of these must have a specific role and what they'll be doing. For instance, when it comes to the medical record side or health information, they do what we call records management. So their access on registration and how that registration process is managed should be what access level you should grant the health information staff. When it comes to the physician, he does most of the clinical documentation. So you grant him an access that will enable him to do all his clinical documentation. The nurse is doing all the nursing documentation. So you grant him access that will let him do such. The pharmacists are the ones that dispense the medications, and you need to give them that function that will allow them to give medications. The administrative staff will also be look at administrative reports, and you need to grant them that level. We also have the IT staff. These are system or technical administration staff, and they do most of the system administration jobs. So you need to grant them the access that will enable them to go to back and solve all the debuggings, assign users whenever a new user in a big facility or big hospitals, you always have people leaving and people coming. You remove the old ones that are no longer with the facility and be able to reassign roles to the new ones that are coming up. So access control is one of the key things you cannot gloss over. Everybody's responsibility must be known. Now let's go back to the audit trails that I mentioned earlier. The audit trails records are important activities within the EMR. It may show who accessed the record and when it was accessed, what was changed, who made the changes, when the changes occurred. So audit trails help you to support accountability issues. You know what everybody is doing. And when it comes to security investigations, audit trails play a great role. When it comes to quality improvement, audit trails. And when it comes to compliance, right? In some countries, you need to comply to other institutional requirement or a global requirement. Like most of our EMRs need to comply to what we call the hospital level 7 requirements, and some of these compliance requirements, the audit trails does most of this. And another security dimension is backup. In fact, backup protects information against hardware failures, cyber attacks, accidental deletion, fire, theft, and also disaster. So you need to have what we call a good backup strategy. Regularly, you need to design a system that does backup regularly. In fact, you can do it every day or every 24 hours, depending on your resources that you have. You can have also automated backups. So it is for best practice, if you are using a server environment, you should always have what we call a mirror server. So as the transactional system is going on, every data or every transaction is replicated on your mirror server. So whenever the main server goes down, the mirror server takes over, and you don't lose anything. You continue your transactions until the main server is back. Then it will re-mirror it back into the main server, and no data is lost. So there are always off-site or geographical backups that you can do or save copies. And anytime you have backups, you should regularly restoration testing should be done to know whether your backup is working as expected. So backups that have never been tested may not be reliable backups, because every backup, once in a while, you must do some simulation test to see whether your backup is working. Disaster recovery is one of security plans that you must know. Disaster recovery refers to procedures for restoring EMR service following disruption. Potential disasters include power failure, server failure. It could be incidents of flood, fire. It can also be cyber attacks, network failures, hardware damages. So to be able to address this, you should always have what we call the disaster recovery plan. And this plan must always indicate the responsibilities, the backup systems that are in place, recovery procedures, communication channels, and then your recovery priorities. Okay, so you need to manage your system or your EMR in a way that business can continue at every point in time. So business continuity focuses on maintaining essential health services during disruptions. So the strategies should include downtime procedures. Whenever there are downtimes, what kind of services can you be taking care of as you try to bring the system back? So all these downtime procedures must be clearly defined and clearly known. Backup power should always have that backup power in place. You should always have alternative connectivity, offline data capturing, emergency contact procedures, that who should call when the system is not working or the system is down, manual documentation procedures. Sometimes if you have to go back to manual for a while, what exactly will you be doing? All this must be clearly defined before the system is brought back. So business, when the system gets disrupted, everybody gets worried. It creates queues, and these are not good things for our facilities. So ensure that patient care continues even when the EMR is unavailable. So even if your EMR is not available, let's be sure that we can continue to provide services. So every EMR that you design should be interoperable. It means it should be able to talk to other systems. Interoperability is the ability of different information systems to exchange and meaningfully use information. So the laboratory information system should be able to talk to what? The pharmacy system. Pharmacy system should be able to talk to laboratory. Laboratory must be able to talk to the National Health Information Platform. So all these should be able to what? Interoperable. There should be that kind of communication between one system and the other. It reduces duplication and improves continuity of care. So to address all these, globally, there are standards that anytime EHRs are designed, and it has to promote what we call, the standards must promote consistency and interoperability. Example is the HL7 I told you earlier about, the hospital level 7 standard. We have the FHR, we have the ICD, and ICD is International Classification of Disease. We have SONMED CT, LONIC, which is mostly for laboratory information systems. We have the DICONS. So why do you think standard matters? In fact, without common standards, different systems may store, exchange information differently, making integration very difficult. So standards are needed. I mean, you need them because that is the only way your system can have a relationship with another system. So you should always go by standards whenever you are developing any EMR. EMR also provide what we call clinical decision support. Way before AIs or artificial intelligence came into being, clinical decision support was what we do those days. I mean, and this mimic exactly what the AI does today, because they are able to tell you, you gather a set of symptoms of a patient and is able to tell you, okay, with headache, with malaise, with bodily pain, this patient is likely to have what, malaria, or this patient is likely to have typhoid. So clinical decision supports also provide you these kind of alerts. Or so there are quite a number of examples that clinical decision support, drug allergies and alerts. So by looking at the person's blood type, XYZ, this, you know that this person will have allergy to these drugs, or drug interactions alerts. So this drug and that drug, if you take it, this will happen to you. Maybe a drug that contains high calcium and the one that we use for typhoid, if you take it, the two combined, you are likely to have some reactions. So this clinical decision supports provide you this information. The caution is that if you have too many of them, it can create a lot of alert fatigue or reduce their effectiveness. We also have medication management. So medication prescribing, medication reconciliation, allergy checking, medication risk history, and medication refills. All these EMRs can support all these and support them effectively. So they are able, for that matter, they might not repeat the same medication, probably look for another one to give you. So EMRs also integrate very well with laboratory and diagnostic integration. For instance, where talk about X-ray lab integrated. Integrations allows results to flow directly into the patient record. So the moment the test is done, you don't need to go back to there to pick your result. It's sent directly to your medical records, and the doctor will see in the consulting room and support his decisions or his kind of pre-treatment plan and kind of medication to give you. It reduced transcription errors. It improved continuity of care. It reduced duplicate testing, and better clinical decisions are formulated. Reporting and health information management. EMRs generate information for clinical management, hospital administration. They are able to get data to support what they do. I mean, it goes into procurement to know what kind of drug to purchase at what time. So health information that will direct or will help in such decision. Disease surveillance, monitoring, evaluation, research, planning, and also resource allocation. EMRs generate information that support this. EMRs And then the surveillance system, EMR data can support surveillance of malaria, tuberculosis, HIV, maternal mortality, outbreak, vaccine preventable diseases, non-communicable diseases. And so the potential benefit is that early detection, it helps in faster reporting. You get to know the trend, geographic analysis, and identification of high-risk populations. So EMRs and also research. EMRs can provide valuable data for research. The applications include epidemiological studies, where you try to look at disease trend, disease quantification, and all that. Health service research, clinical research, outcome research, quality improvement. So in all these, you need to consider the quality of the data you are using, the privacy, ethically, are you approved to use that data? You need to also look at data governance issue. And anytime you have to use data for research, and so you must make sure that the identifiable features of that data is de-identified so that we cannot link that data to any individual. When we talk about data governance, here we are trying to establish how the information is collected, stored, accessed, used, shared, protected, retained, and disposed of. So if you use the data for some time, you need to know how you dispose it of. So effective governance requires clear roles, clear responsibilities, the policies that you have in place for the EMR management, the standards, and also the accountability mechanisms you have in place. Okay, so the legal and ethical considerations are key. So I strongly believe, I've been telling my health information guys the other day that every health information person must end up as a lawyer. What I mean is that you must become a lawyer by force, because by knowing all the legal requirements or ethical considerations of managing patient records, you must move on to qualify as a legal practitioner or a lawyer. So EMR management must consider the patient's confidentiality, privacy, informed consent where applicable, data protection, appropriate information sharing, professional accountability, data retention, and ethical use of information. Healthcare organizations should comply with applicable national law and professional requirements, because I think a week ago I was following the news, and I think Ghana Health Service said they have their highest suit or court suit against them in the year 2024 and 2025. So it means people are becoming aware of how their medical records are exposed. So they can easily take your organization to court, and you as the custodians of the data must be aware of some of these things and clearly know what to do. So clearly, to address all that we spoke about earlier, user training is key. Training should occur before every EMR is deployed, and training during implementation, you need to train. Training after some time, you need to train. You should continue, because there's always high attrition of people coming and leaving. So training, you should train on system navigation, you should train on clinical documentation, you should train on data quality, train on privacy, security, password management, downtime when the system is down, what everybody should be doing. But if people don't know what to do, the moment the system go down, they are the ones that will spread false alarm, and they will start scaring your client. But if they know it and know the procedures and what to do, they will just quickly step in and start doing what is expected of them. Reporting, you need to train people on how to report. Change management, I mean, nobody likes change, but change is also good. So anytime you are introducing an EMR change, how health workers perform their job, because there's some that will fear that they will be losing their job, and there should always be that assurance that they are not going to lose their job. So such people, there's likelihood of some resistance from such people, fear that the technology, increase workload during transition. So if you can remember, when some facilities automate, instead of the queues vanishing, the queues rather increase. Why? Because people fear that they will lose their job, so they will intentionally or deliberately start working against the system. So what they will do is that they'll make sure the system doesn't run fast. They'll make sure they will slow it down. They'll do everything to be sure that the system doesn't yield the desired result. So there's lack of confidence, poor system design, inadequate training, fear of monitoring. People fear that people will see what they do within the system. So they try to avoid the new or the EMR. They stick to their old manual way of doing things because of some of these things. So to address some of these gaps, change management strategies that you should put in place. One, early stakeholder involvement. Involve everybody, including the user. Communicate everything. Let them know what the system will bring on board. Train them. Have users that are super users for every unit. And these people will serve as what? Unit champions. They will champion the source of that MR. And then they will train others to provide leadership support. And then there should always be what we call the feedback mechanism. People, when they have challenges, there should be somebody and a hotline they can call for support. That should always be there. And that support system should be there. So anytime you design EMRs, you should do it with a user in mind. So it should be user-centered. So a good EMR should be designed around the user and the clinical flow systems. In fact, if you think only about the user, you fail. If you think only about the clinical flow systems, you fail. So these two must go handy. So these important characteristics include ease of use. It should be simple to navigate. The screen should have logical screen that maybe the menu should be there. These are the files. This is what I have to do. If I want to register a client, I go here. If I want to give treatment, I go here. If I want to assign medications, I go here. So all these should be clear. There should be appropriate alerts. There should be fast response time anytime the system go down. Accessibility should be there. So when you are implementing EMRs, it goes through what we call life cycles. So a typical implementation life cycle, you need to know what we call needs assessment. Do what we call needs assessment. You need to engage stakeholders. And then after engaging the stakeholders, you move on to define your requirements that you need for that system. Then you go to system selection. So if you will develop it yourself, you look at how that will be done. But if you have to acquire it, you look at what you need, or you look at the vendor requirement so that when you are purchasing, you know what exactly you are buying. You need to know the workflow analysis, check for configuration, test it. Training is key during the implementation cycle. You need to start small, pilot it in one department, see how effective it works, then you move to the next one. Full implementation, you have to monitor it, and continuously you need to have that support that is there. Whenever the system, there are bugs, they go back to debug them. That support system should always be there. Okay, so there are some qualities you have to look out for anytime you are also buying or selecting an EMR, or even you are building one yourself. The key things you must know before selecting an EMR. One is that the functional requirement. You cannot do without this. You should know what it is going to give you, the cost, the scalability, interoperability, security system. Will the data be secure? Usability, is it user friendly? technical support. Is it people buy softwares that do not have technical support systems? Because once you deploy it and the technical support is there, a bad software with a very good technical support will last longer than a very good software without a technical support. So vendor sustainability, are they only selling that product? That means tomorrow, if they are not in the market to sell anything, you won't get them tomorrow. So you should know the kind of vendor you are also dealing with. Does it also offer online, offline capabilities? Because the system downtime, if you are using the internet connectivity, that internet card will always be there, and you must make sure you have a system that can run without the internet. Reporting requirement. I mean, those of you from Ghana service know there are a lot of reporting requirements and every month you need to generate. Is the system able to do that for you? Or is it only, I remember one of the systems that was deployed, people were talking that it can only generate health insurance bills because that is what managers are interested in. But the other reporting models where the system could not generate, then manually people have to start guessing data to fill in returns format and submit monthly. So whenever you are doing system selection, these things, this you just have to tick this box before you can proceed. A costs like this, you cannot, you look at your budget and also. Okay, so EMR also come with its own challenges, and but just like any other system, these challenges will include limited funding because some of the software could be so expensive. If one entity want to buy them, the cost is so high because you are the only person using it to providing all the support, it becomes high. But if there are a couple of sites using it, then managing it is quite easier. So you should look out for some of these things. Inadequate infrastructure, you don't have the needed infrastructure, poor internet connectivity, power interruptions, poor data quality, lack of technical support, cybersecurity risks. Is it? You should also see some, we have challenges with interoperability. They can't connect to other existing systems that are there. So these are things you should look out for. So to address those challenges, you need to establish strong leadership. Leaders is, is important to engage users early, conduct workflow analysis, provide continuous training. Data quality assessment should be there. Improve strong security controls should be there. Should have a reliable infrastructure. Monitor performance regularly. Technical support and then continuous improvement of the system should be there. All the time you should give an update. So you also need to also be monitoring the performance of the EMR so that at every point in time, you see whether it is working as expected. So possible indicators to do one in the system side, you need to check the system uptime and also system response time. Also check the number of system failures. These three indicators are very useful. When it comes to users, check the percentage of the users that are trained. Check the satisfaction of the users and also check whether the user system with like see the users are using the system as expected. These user indicators are key. When it comes to data indicators, you need to look at for completeness, accuracy, timeliness, and consistency. We've spoken about this a lot. We also have the clinical indicators that you need to watch out for in your EMRs, documentation, completeness, medication errors, turnaround time for results. All these need to. So, so a lot of these are key whenever you are deploying EHR. So let's look at this case scenario or case study scenario. A district hospital introduced EMR system, and then 6 months later, the clinicians complain that documentation takes too long. The nurses frequently share passwords. laboratory results sometimes missing, internet goes down, managers report poor data quality, and some clinicians continue using paper notes alongside the EMR. So what do you think are the major problems here? Which EMR principles are being violated? What should management do? What indicators should be monitored? And how can users or user resistance be addressed? Because I remember then when they were deploying iHosts across the regional hospitals in Ghana, I remember Trafalgar, a former medical director of the hospital, said he would never use the iHost. And this is a very powerful person. So if that person is telling you not use it, I mean, it means there's a big challenge here. But these are the questions you should ask. And these are the questions at every point in time you need to provide answers to. So the key take-home message here is that an effective EMR is not simply a computerized medical record. It is an integrated information system that connects people, process, technology, and data to support a safe patient care, efficient health services, quality improvement, research, and evidence-based decision making. So on this note, I will say thank you. And if you have any other questions, I can come in. Thank you, and over to you, MC. Hello. Yeah, I'm done.
Oh, sorry, I was muted. Sorry. Thank you so much, Doc, for that insightful presentation. And so the floor is open now. If there are questions or comments, we'll give you the opportunity to ask them. So kindly raise your hand, and we'll give you the opportunity to present your case. In the meantime, the registration link has been shared in the comment section, and so kindly click on the link and then you register. And then for those of you who are asking about your Ghima registration number, kindly get your Ghima ID. Remember, all Ghima members are supposed to be duly registered in our membership database. And so once you register, you are issued a unique ID number, and that is what identifies you as a Ghima member. And so kindly, if you have not yet downloaded your Ghima ID card, kindly
Am I the
log
only person
into
who
your
cannot
account
hear
on the
anything?
Ghima registration link, and then download that, and then you will get your Ghima registration number. So the registration address has also been posted on the platform or the chat box for you to access. Thank you very much once again. And as I said, we have two hands up. I will call them in the order I have it on my phone. And so, name. My learned brother, Anas Belateria.
Yeah, Anas, good afternoon. Can you hear me?
Yes, we can hear you.
Okay. Good afternoon, Dr. Asem. Thank you for the very deep presentation. Next year, by this time, I pray hard that once we meet again, you are a professor. Thank you very much. Now to my question.
Thank you.
I have just simple two questions. One is on confidentiality within the EMLR. Then the second one is on security. So with the confidentiality, I wanted to find out at what time or at what stage will one's right to confidentiality begin? And at what stage would that right to confidentiality end? And I'm going to give a scenario which I was one engaged in. I was one engaged in what do you call it, an HIV coordinating program, whereby we have a woman who is an HIV positive. But after going through the process or the program and the counseling, what she put before the team was she doesn't want the husband to be aware that she's positive of HIV. And as health workers, as health professionals, we need to protect that information. But at the same time, within our laws, we as health professionals are also bound by the law to prevent other clients or other people from what? Contracting a deadly virus. So if you find yourself within this preview of what engagement, what will be your what do you call it? Your reaction between the man, the husband, and the wife. One ready for you, one telling you not to let the husband know that she's positive. And that is her.
Okay,
That is,
so
yeah.
I think you are, if I understand you clearly, so
Okay.
this clearly is an issue of confidentiality, right?
Yeah.
And these confidentiality breach are there all over the place, but there are legal requirements and institutional requirements. So even though I understand where you are coming from, maybe as a provider, you are speaking from the point as a provider where you need to make sure transmission is either you stop it or you reduce or
Exactly.
you slow down transmission as much as applicable. I get all that, but
Exactly.
all these situates, if you heard me clearly, we spoke about the ethical and then the legal frameworks that governs our job that we do. And if the law say you shouldn't, and the law also equally permits you not to tell the husband, please, the law is super here. And if you just go with emotions and you say that because you are a provider, you need to uh, you have to stop the disease, and for that matter, you have to tell the husband you'll be following or you'll be playing with the law. And if you don't take time, when that person takes you to court, the court will deal very harshly with you. You know, Ghana is governed by constitution. We have the criminal code. We have a lot of institutional codes that also get us. We also have the Data Protection Act. Do you know this? The Constitution of Ghana, Criminal Code, Data Protection Act. Even within these three laws or these three codes, you can clearly see that if it says that you shouldn't do it, then so be it. There's nothing you can do about that. Even no matter how beneficial you think or how good you think you will do to the whole country. The law court will not be interested in your good that you want to do, but it will see that what has the law got to say, and that is what exactly punishment they will hit on you. So
Yeah.
that is my answer on that. But
yeah, thank you very much.
okay,
Then with the second one, which is security within the EMR system.
yeah. So
Yeah.
security is in different levels and it's in different layers. So I mentioned the various kind of security backup plans, but what you mentioned, the clear thing is the access control rules. So if every user your roles determine what exactly you can see or what exactly you can do within the system, that will be able to mitigate or cure that kind of people's information leaking or when there is information breach or there are security breaches. So clearly, when your roles are clearly defined, you know when to start and when not to start. That is all.
I think
Okay,
where I
so
wanted,
yeah, let me hear you.
yeah, I think where I wanted to come from, the angle that I wanted to come from is you realize that now individual protected personal information is becoming like what do you call it, a cash flow for hackers, especially within the sub-region. Though maybe Ghana, we haven't started yet experiencing that. But if you go to places like Kenya, Rwanda, and the rest, if people are able to hack into your system and get access to individual protected personal information, let's say, for instance, for people like influential people, politicians, they become money for them. So what sort of, because these sort of hackers, you are also using some sophisticated, what do you call it, instrument in hacking into people's, what do you call it, network or infrastructure system. So what do we do? I heard you mention a lot of the access control, but despite all those access control, these people find their way in, hacking into systems and doing away with people's personal information and with insiders, which are part of us, with the help of some insiders who are health workers who accompany these people to get this sort of information and become
Okay,
money for them.
so I think you are clear. I get you
Yeah.
clearly now. Okay, so the thief will always come, but that is why we have the laws. That is why we have the criminal codes. That is why we have the Data Protection Act. That is why we have rules and regulations. That is why we have standards. So all these are supposed to guide, but the thief will come one day anyway. But when he comes, you are making sure that your security system are there so that you can address these challenges. So I always tell my students, whenever I'm teaching them information security, that you cannot stop the thief, but you can make it difficult for the thief to steal. That is by activating all systems that it will delay the thief stealing you. So one, you don't keep logging into unnecessary website with your personal information. Another one, be sure as an employer, you have to know who you employ and what that person does in your organization. And at every point in time, if you employ somebody to be on your information like that, that is a high classified information. You need the security agencies to come in to do a background check on that person before you employ and before you allow that person to work in your organization. And so the bank do this a lot, but I know the bank also go through their own in another way. People go there and money to cash on them, steal some of divert some data into an account, go and clear the money and then resign, run away, delete all their information. The audit trails will show, but sometimes it takes a long time to trace, track, and finally some of them are caught, some are never caught. But at every point in time, we learn lessons, and with the lessons we learn from the past, we make provisions for the future. So whatever weaknesses we identify in the past, we find ways in the future to be able to mitigate them. And so this is what I can say for now. So clearly, the legal framework, the policy frameworks are supposed to help you so that, in fact, there is no straight answer to this question to say that when you do X, Y, Z, your system can never be hacked. No, you put in all the layered security. You can use different level of authentication using the password. You can use the card. You can use the biometrics. You can use whatever. People can still find their way around it. But if there are good laws, there are good policy system, there are good plans, or there are good data protection guides, it will be difficult for the criminals to do this. So that is what I can say for now. Okay, so
Okay, thank you
maybe
very much. Thank you.
Doc,
we can later do a
Yes, sir,
side
Doc.
talk and probably we can discuss this further.
Thank you, sir. Thank you.
Okay.
Thank you.
okay,
I'm grateful.
yeah, hello, Doc.
Yes,
Yes,
please
okay.
go ahead.
Thank you very much. Okay, thank you. I just want to add something small to the brilliant answer you gave to my brother Anas. The Data Protection
Let's go.
Act
Let's go.
also says that if the personal data under your control is being compromised, you, the data controller, take the necessary steps as soon as possible to inform the stakeholder. In this case, the stakeholder include the data subject, the persons whose data has been stolen or has been compromised quickly. But we, the health information officer, we don't have that power to go ahead to do that. What we can do, if we detect it, we should, as soon as possible, report to the authorities of the facility where we work, and they will go ahead. If they need our advice, we should inform them. For instance, the head doesn't know that we have to report to the data commission, personal what do you call it? Data commission, and also inform the data subject. We have to give this information to them. Then they go ahead and do as the law prescribes. So this is the limit within which we can operate. Beyond that, it is left with the authorities or the higher officer to do what is necessary. But health information officer, we have to inform the authorities under whom we work. That is important as far as my understanding is concerned. Thank you very much.
But that was the last place that we went to.
Okay, so Timothy Mensah, let's hear you.
Okay, sir. Congratulations, Doc. My question is that goes to I wanted to do a follow-up for the Anas question that he asked. I'm about this in confidentiality purpose. My question is that is it necessary that we allow those casual workers to manage our IT department? Because most of their facilities, their IT managers are casual workers, and most of them can leave at any time. And the confidentiality purpose, that's what I wanted to ask. Is it advisable to do so in our facilities? Thank you.
Okay, so to or not. Let me let me also ask you, how long have you worked? Where do you work?
My question is not about me. I'm talking about the
Okay,
generality purpose.
the whether the challenge is that it depends on the organizational arrangement. If the employer resources to employ a permanent staff and he engaged a casual staff, but I think the key thing there is that that staff should be well oriented, well coached. You need to teach him issues of confidentiality and privacy so that be there. So that is what I can say for now. But I know in Ghana service it take a long time to do one recruitment. So that it might take 10 years before they will recruit such staff. And when it happened, I know an IT staff who was a casual for 14 good years in Ghana service. And eventually he was not employed and has to leave. So these things are things that happen in our organizations that we
Okay, Doc. And okay, thank you so much, Doc.
Stone, that person can ask his
Doc.
question now.
Yes, so Stone, go ahead and unmute and ask your question. Yeah.
Hello, Stone. Okay, so once we wait for Stone to unmute, once you are employed by an organization, whether you are employed as a temporal staff or casual staff or a permanent staff, you are bound to work within the organizational rules and regulations. And so if casuals are working with the Ghana Health Service or the health system, they are supposed to abide by all our ethics and procedures. And so if they violate that, the service knows what to do. And so I'm just adding on to the question that my brother asked earlier on. I think Stone's hand is down now. Please, is there still any question to be addressed?
So if you permit, I have a small one to ask, Doc.
Yes, please proceed.
Okay, thank you very much. Doc, thank you for the presentation. A very good one, and it is expected. We know who you are and what you do for us. I realized that some of the things you presented had to do with policy decision. And as health information practitioners, we are not at that level to take some of these decisions. So practically and realistically, I want to seek, though it appears putting you on the spot, but try, I know you give us advice, ask what we can do when it comes to policy decision regarding some of these things that you have taught us, which some seniors are already aware. Example is EMR system selection. Who takes that decision? We know what should do, but somebody else somewhere will take that decision and impose it on us. So when some of these things happen, what do you think we should do as health information practitioners in the context in which we practice in Ghana realistically? What should we do? Thank you, sir.
Thank you for that question. And that is, it's an important question we cannot gloss over. And earlier when we started deploying EMRs in Ghana, most facilities, by then the health information space was not that developed, that we have this kind of well-educated guys like we had before, like earlier ones. So it was difficult to even say that they should sit in a meeting to make a decision on how EMR should be acquired. But over time, the space has grown. A lot of you have shown maturity, or should I say growth. And I think you understand the issues now better than then. And it has become necessary that we know some of these things, even though where we stand now, because there's a strong political undertone that has even gone into how the procurement is done and which me and you cannot do much about that. But what we can do is that within even the political cycle, it's one of us here who become the politician. And since it's one of us, the next politician in line could be you, it could be me, it could be anybody. So we must know how these things are done logically, so that if there is an opportunity to clearly involve everybody, we will not leave anybody behind. So my advice for now is that we just have to position ourselves for leadership, and in no time, we will be the next level of decision makers. Thank you.
Thank you very much, sir.
Okay, so can I wind up if we don't have any other question?
Yes, Doc, you can please proceed.
Okay, so currently AI has come handy and it is a tool for the future. So as health information practitioners, we need to acquire an AI competency skills. And so I was discussing it with Fumado the other day. So maybe we can look at that, and then we also understand the legal framework information space. So Fumado will work on that, and we'll get back some other day in the future. But I want to thank everybody for the opportunity and to wish everybody well. And I believe in no time, health information will be one of the best professions. People will jealous, people will struggle hard to become health information officers because a lot of guys have grown professionally and you now understand how to navigate your space very well. So on this note, I'll say thank you and then I'll end it here. Over to you, Chairman.
Thank you.
Presido.
Thank you very much. Thank you very much, Doctor, for today's session. We are very much grateful, and we pray that the Almighty God will continue to guide, bless, and protect you so that we'll continuously tap your knowledge and wisdom for the betterment of our profession. So thank you very much, Doctor. We are very much grateful. I hope everyone has registered now. As I mentioned earlier, the registration link is posted in the chat box. And so let's all do well to try and register. For those of you who don't have your membership registration number, kindly contact your regional governors. They will assist you to navigate the registration process. We have done orientation for this registration activity a number of times. We are in the second year of registration. And so it is our expectation that we should have all members registered in the membership register. And so if you have not yet done so, kindly see your regional executives and they will support you go through the process. So thank you very much all once again. Until we bring you another exciting edition tomorrow on how to manage our mental health at work, I will say good afternoon to everyone and stay blessed. See you all tomorrow. Goodbye.
Bye.